femoral embolectomy already been explained and given a lecture by Mr. Faisal early today. And then I divide then to the embolectomy procedure itself, how you want to do a surface marking of it, the embolectomy procedure, and the option of the closure of your arteriotomy. So we're looking at the post-operative result. Sometimes your embolectomy fail to revascularize the limbs. So what's the pitfall of the embolectomy? And also some adjunct procedure that you can do together during your embolectomy procedure. Right. So yes, Hazwan, so I'm not covering brachial embolectomy, but I already give you the the answer that you asked just now, right? Okay, first, how you wanna prepare your patient for the femoral embolectomy? So is it under GA or under local? So what is the best to offer to the patient? Anyone? Can I see a hand for general anesthesia? Anybody? What about local? Come on. Okay. Alright, so I see more towards local. So yeah, as most of patients that are presented with acute limb ischemia, more than 80% of the etiology comes from the heart, right? So that means that the patient may have some cardiac issue, such as AF, dilated cardiomyopathy, which is for our putting the patient under GA could be our anesthetist want further assessment of the heart, echo, something like that, right? So it may require a bit more time for those assessment if we proceeded for under general anesthesia. So putting the patient for embolectomy under the GA may require more time, which is what the patient did not have at this moment, right? Once you decided, you have the correct diagnosis, okay, you already have the correct grading of the ischemia of the limbs, so you already decided for the femoral embolectomy. So I think the local anesthesia is the best if you want to save time and for the patient itself. So in addition, other than your anesthesia, other lab assessment that you have to do for baseline investigation, such as your renal profile, right? In case that we want to do a on-table angiogram, so you have your baseline of renal profile of the patient, and also creatinine kinase CK level, the baseline that you can do a comparison after your embolectomy. Post-operatively, you may repeat, see whether there's any decrement level of the CK. Okay, straight to the procedure itself, femoral embolectomy. Okay, before you make the surgery, first you have to mark the incision site. That means marking the surface anatomy of the femoral artery. So as most of us already know, that the femoral artery lies in the midway between ASIS and symphysis pubis. Right? So is it true, everyone? So is the surface marking of the femoral artery lies in this ASIS and symphysis pubis? You make some research of it? New papers? No? Okay. Yeah, so a few papers actually have come out that this is true only in 15 to 30% of cases, right? So it's a new finding. So the rest of it actually lies about 1 to 1.5 cm, either lateral or medial to this line, right? So this is why this happened. So because it's actually based on the patient body habitus, right? So and then how you position the limbs during the procedure, whether it's in an anatomical position or the patient the leg is a bit rotated, externally rotated or internally rotated, everything affects, right? So other than that, is based on the patient size itself, whether the patient is too fat, right? The thickness of the inguinal region is too thick, and then any surgery that has been done before at the inguinal region, all these reasons affect the surface anatomy of your femoral artery. Next, you have to infiltrate the skin that you have marked with local anesthesia. You can use either lidocaine, marking, or in combination of both. Further LA may require as you go more deeper, especially at the periatrial tissue surrounding it. So have your anesthetist standby in case that your local anesthesia is not that adequate. You may want the patient to be sedate, right? So have your anesthetist ready. Okay, next, you can use your self-retaining retractor, either small or medium size of Mollison or Webiner retractor. Use a sharp dissection. Always do a sharp dissection along the periatrial tissue when you're approaching and when you want to dissect the artery, right? So try at this point you can use curved Metzenbaum scissor or vascular Raynaud scissor if your center have it, right? So if you don't have, you can use just a curved Metzenbaum. So use non-traumatic, non-tooth grasping forceps such as DBK forceps to grasp the periatrial tissue. Try to avoid grasping the artery directly. So next, if you identify all the 3 branches of the femoral artery, double loop all 3. Right? Sometimes you may find small branches coming out from the CFA itself. You can loop it temporarily with suture, or you can use a bulldog, right? Temporary clamping. So after you double loop the thing, next you want to do the arteriotomy, right? First you have to clamp, right? Clamps those artery with non-traumatic vascular clamp, such as DBK clamp here, right? All 3, 1, 2, another 1, 3. Next, use blade size 11 to make the first puncture of your artery, right? In a manner of a step down and go forward a bit. So if you do this correctly, right, you will see the thrombus pop up in your eyes. Why I say correctly? Because sometimes the blade that you do during the arteriotomy is not that deep, so it may not cut through the intima. So the intima didn't break. So you may create a flap actually, right? Okay, next step, you have to prepare your Fogarty catheter. You can use, there's so many appropriate size of Fogarty catheter that's available, but usually for lower limbs, you can use either size 3 or 4 French. So use saline or air to test the balloon before you put it in. And please do not use any recycled catheter, okay? Because it can rupture during the procedure or even when you test it yourself, right? So please use a new one, right? Okay, then you can start with the embolectomy. Usually what I do is start with the establishment of the inflow. Okay. So go upwards from your arteriotomy to the external iliac. So first you have to measure the length of the catheter that you want to introduce from your arteriotomy upwards to the umbilical level. Right? So you introduce, once you introduce your Fogarty upwards, you have to loose the vessel loop, release the clamp, control the hemostasis with your vessel loop. So once you introduce it, inflate it based on the recommended size, and then you pull up and see the inflow of blood. So the best for inflow is you will see the gush of blood, right? From the proximal, there will be a gush of blood. So you have to protect the wound area with your hands. So protect yourself and your assistant and surrounding, right? Because there will be a lot of splash of blood if you don't do so. So you may repeat this process several times until you have finally get a good gush of blood proximally. Right? So, and then once you finish with the inflow, you tighten back the vessel loop, release, put back the clamp, and you go to the SFA. So the same manner, you have to measure from the arteriotomy to the level of the ankle. Right? So the aim here is to pass the catheter balloon smoothly to the level of the ankle. So do the arteriotomy, pull up, and you can pull out all the clots. So once you already pull out the clot, see the backflow of the blood. It may not gushing out as the proximal one, so but you have to see the amount and the color of the backflow of the blood. If the color is red, arterial red, so probably it's adequate. But if the color is a bit black, that means some residual clot still remain inside, so you may repeat the procedure again. Right? So you do the same manner with the profunda femoral artery. So once you get all the clots, you can put it in dressing and take a picture of it. So records. So next, once you do all that, insert the smaller size of feeding catheter distally to the SFA first. You may need to do this on your proximal part, right? So once you insert the catheter here and then tighten your vessel loops to prevent the backflow of solution, flush with 100 to 150 cc of saline, right? Totally flush everything. Okay, do not lose the vessel loop. So with a hyperliner saline, you do this also with the same adder, your profunda femoral artery. So yeah, there you go. You completed your embolectomy. So next is to decide on the arteriotomy closure. So provided there's nothing goes wrong during the procedure, meaning that you already obtain a good inflow of blood and good backflow of blood distally, so you can proceed with arteriotomy closure. Any question at this moment? No? Alright. So okay, how you want to close your arteriotomy? There's two methods. You can use either continuous suture, or you can use a patch repair, either vein or PTFE patch repair. So when to decide? It depends on the femoral artery size. Right? If the femoral artery size is big, more than 5 mm diameter, you can use continuous suture. Always use monofilament, non-absorbable, round body Prolene, 5060. Right? So, but if the femoral artery is small, sometimes because of patient is elderly, usually the femoral artery is small, you may have to repair it with vein patch, or if you have PTFE, vein patch repair. Right? So you have always to bear in mind that to achieve a good hemostasis before during the closure of the artery, because this is we wanted to prevent hematoma, the development of pseudoaneurysm, and later on infection, which will further complicate your arteriotomy. Right? Next, after the closure of the artery, we have to put a vacuum radivac drain, okay, to the surgical site, come out to lateral to the wound. Okay. But because we have to put a drain, it depends whether your how big your tissue dissection involved during the procedure. With the patient a bit thick, so you probably need to put it, because bear in mind that after the procedure we need to start the patient on heparin infusion. So any collection later on, hematoma over this region could jeopardize into infection and wound breaks down, and the breakdown of your arteriotomy closure, right? So what are the adjunct procedure that we can do following your embolectomy? On-table angiogram, you can do fasciotomy, and heparin infusion. The on-table angiogram, provided that you have a good fluoro machine in OT, you may require the angio if in the case of you receive inadequate or unsatisfactory backflow of blood despite multiple time passage of your embolectomy catheter. So this usually occur if the patient had more distal embolus or thrombus, and once identified, the patient may need a more distal embolectomy, such as a popliteal embolectomy. Right? So you may need this angio machine to rectify what actually the main issue or thrombus if you don't have adequate backflow during your femoral embolectomy. So fasciotomy, 4-compartment fasciotomy is required if the limb is tense, swollen, and may progress to, they really think that patient may progress to compartment syndrome later. Fasciotomy will facilitate the distal blood flow by releasing the pressure in the lower limb compartment. So the last is heparin infusion. You may start for a few days. After that, you can start before you starting your anticoagulant. Okay, what are the pitfall? Why sometimes your embolectomy fails? So this is the possible causes, the pitfall of your embolectomy. It can be because of wrong etiology. The patient may have a ruptured plug, and then the plug dislodged in the femoral artery. So you try to do embolectomy because sometimes the plug is very hard, difficult to retrieve it. So that's why it may sometimes your embolectomy fail to establish blood flow to the limbs. Correct? And then the technique that and equipment that are available at your center, how the technique, the surgeon experience of doing femoral embolectomy. Delayed intervention, probably the limbs is already too late to be salvaged, and although embolectomy performed, sometimes the patient may lose their limbs also. This also same as the underestimation of the grading of the ischemia. We use Rutherford grading as described by Mr. Faisal just now for the grading of the ischemia. You cause intimal damage during the procedure itself, right? Sometimes because of the excessive inflation of your Fagati catheter, so it can cause intimal damage somewhere distally, which we cannot see at our arteriotomy site. So it can cause a propagation of thrombus more distal. And then the last one is very impacted embolus in the vessels. You may have your embolectomy fail to revascularize the limbs. Okay, with this slide, I end my presentation. Any question you can ask.
Just a comment on the last slide. Let's go back to the last slide. Just a comment, not to you, but to the rest of the participants. I think if you look at intimal damage, I think Mr. Azam has mentioned certain things, but I think one of the common causes of intimal damage is, as Mr. Azam mentioned earlier, is because you reuse catheters. You know, if you look at the catheter, if you have a picture of the catheter, you see the tip and all that. It's all smooth. There's not supposed to have any resistance. But you know, can you imagine if you put it a few times in one patient, and then you send it to CSSD to be recycled, and then they pack it up again, and then you use it again. Balloon bursting is one problem, but sometimes, well, before the balloon bursts, as you put the catheter down, you look at the tip. Maybe we can look at your catheter. There's one that shows the tip. You see, it's a problem. Before that, you look at the tip. Okay, the slide was okay. The one, yeah. You look at the tip. I mean, you see how smooth it's meant to be. You know, these are all used ones. So even sometimes during a procedure, if you're not happy with the catheter because it's bent, you can use another one. I think our record is somebody used 7. There's a record, somebody used 7 catheters, and you guys are arguing about one catheter. I mean, sometimes you have to use 7, 8. Maybe that was a bit excessive, but I think, most of you who are surgeons here should actually have a minimum of 2 of each size. Minimum 2 or 3. And they're not very expensive. They're only 100 something per catheter. And I think it's important that you must use it. That you mustn't reuse it. And even during the first use of using it, you must make sure that the catheter is not bent, damaged, because sometimes it can happen. Okay, so I think that's one of the preventable ways of preventing yourself from getting a pitfall. Is to use correct instruments, consumables, and not try to stitch, because this is not expensive.
Mr. Azam, I have a question just for clarification.
Yes.
When you release the clamps, do you release the SFA or the PFA first, or does it not matter?
Usually it doesn't really matter, but usually we release the SFA first before we release the PFA, because we want to actually we don't want the blood clots to goes into the PFA actually. So PFA is the one that the vessel that we want to maintain it. Yeah, and also the de-airing part. Just forgot.
In a hospital which actually the vascular disposal for like consumable is very lacking, I find that they tend to recycle about 3 to 4 times until it bursts. So I purposely burst it after 3 times so that they don't reuse it after 3 times. Yeah, but I think if I burst it first time, I wouldn't have any balloons for me to do embolectomy. So 2.6 billion would be very, very, very good to spend on. The other thing is that if you notice the syringe that they use to do the embolectomy, it should be the one with the lock. With the lock.
You have to, the lock.
It is not the syringe that they use for the anesthesia to deliver the medication, the smooth, without any the screw. So by the time you inflate the balloon inside the artery, by the time you retrieve, the balloon is now of a smaller size, and then you don't get the proper evacuation of clots. So that's why when I let junior surgeons to do it, they tend to retrieve very minimal amount of clot rather than if you do the proper one with the lock. So to ensure to maintain the balloon, the size of the balloon within the lumen is very important. Otherwise, you won't get very effective evacuation of clots. Thank you.
Thank you, Mr.
In May 2013, I was sitting for my second part exam, and I had a viva in the operative table, and Mr. Hani was one of them. And I was asked a question on how to do a femoral embolectomy. Do you want to know what questions he asked?
Yes.
One of them is being asked by Hazim, and another question was, when we do the arteriotomy, was it transverse or longitudinal?
It's always longitudinal. You can transect the artery.
Actually, the questions that Hazim asked, the answer actually is we should be opening up the PFA first before the SFA.
Two schools of thought on that. The school of thought is that it depends on whether you start using the SFA or the PFA. If you feel that your catheter has gone all the way down and its SFA is clear, then you should open the profunda first. And profunda is a sacrificial just in case, but the de-airing is actually the most important. But if you feel that your SFA has failed and there's a there's some narrowings in the SFA. The profunda is actually going to be the main outflow, then the profunda. So the basic theory is very simple. You save the artery that you think is going to be the main outflow. So it depends. So if you put your catheter down and you feel there's a lot of flux in the SFA and you cannot go down the SFA and you have not actually successfully done embolectomy down to below the knee, then you will say that most probably the profunda is your main outflow for a while until you sort out this patient. Then you let the profunda be the outflow that's last. That becomes last. The most valuable outflow obviously is the last one. But saying that, like I said, the de-airing is actually the most important.
I think I need to ask Dr. Zainal. If, let's say when we try to salvage the PFA, but the PFA is thinnest because of the plug, would we do the profunda and arteriotomy in the same sitting before the closure?
I mean, if you're a vascular surgeon, you can do it. But I feel worried that if you're not and have no experience in arteriotomy, then I guess you have no choice. You can't do it. I mean, you can do it, but most probably you can't do it. You have a lot of problems. And arteriotomy is not so bad. So I think if you're a vascular surgeon, you can. But if you're a general surgeon or a MO having to do that, then it comes under the last slide again, it becomes a pitfall. Most probably, if you find all those artery and you find all those arteries there, then it becomes either wrong etiology, that means it's actually thrombosis with a lot of underlying disease, clots, or it becomes a lack of technique, that means within your experience, and maybe you don't have a correct equipment at the moment, because many people may not have a patch, may not have the right sutures and all that. So the pitfalls, as Mr. Azam mentioned, is what, if you have that kind of problems you have mentioned, you fall under one of these. That's why pure embolus from the heart, stuck, classical as the pictures that Mr. Azam showed, should respond to those standard things. But once you have underlying atherosclerosis, poor equipment, reuse equipment, you fall under one of those. That's why it's unsuccessful.
Actually, back to the question of the arteriotomy, I mean, some of the hospitals will not have a patch, and they may not be able to. So I was just thinking, is transverse arteriotomy would be sufficient?
We always use longitudinal. I don't find it that transverse, because when you do a transverse arteriotomy, you can propagate clots further, because when you see the blood flow of the way of your blood flow against the transverse incision, right? If you don't have a vein patch, I mean, you don't have a PTFE patch, you can always use a vein, right? The adjacent vein, you can prepare the legs at the same time to get your long subvenous vein. For that, I mean, prepare the leg at the same time. So if you really think that the artery is small, so yeah, you can stand by the legs at the same setting.
Okay, any other questions that you would like to ask? With that, we end our lectures, not session.